Okay, we just finished talking about wound care, so now let's talk about pressure ulcers. These are wounds that are happening from unrelieved pressure generally, and that can be pressure from a bony prominence getting, the skin getting squished between a bony prominence and a hard surface like the bed or a chair. It can be from tubes. So we're going to take a look at these in more detail. And when we're looking at pressure ulcers, we had already talked about the skin with our wound care. We said it's part of the integumentary system. It's one of the largest organs of your body. You've got the epidermis, which is the outer layer, and the dermis, that's part of your skin. And then you have the subcutaneous layer, which is the connective tissue and the fat layer. Our skin generally, it will support underlying body structures for us. It maintains body temperature. So as I mentioned when we talked about wound care, when you get cold, your body starts shivering to produce more heat. When you get hot, you start sweating to help get rid of some of that extra heat. So it helps maintain body temperature. It also is a source of sensation. So it's you have heat and cold receptors and pain receptors. So it gives us a sense of sensation. We can eliminate waste, okay, with our sweat, with our perspiration. It protects us. It's our first line barrier, we said, against infection. So keeping it intact is very important to prevent infections. And then we said it also helps us synthesize vitamin D. So things that impact the skin. One is dryness and aging with that. So when we get older, so normally your skin has, it secretes oils, which helps keep your skin lubricated and moist and helps keep its integrity more intact. As you get older, your body quits producing as much oil and the skin becomes much drier. The other thing that happens with the skin is you start losing some elasticity to the tissues. So the connective tissue layer tends to start breaking down. You lose the subcutaneous layer of that fat, which is there for warmth and protection. So because with the aging things that happen to our skin and the dryness that happens, it can truly set somebody up to be more prone to wounds and to be more prone to pressure ulcers. The other thing that's going to impact skin is mobility or lack of mobility. So if you have a person who's had a stroke, for instance, and now they can't move one side of their body, or you have a patient that has multiple sclerosis, for instance, where they aren't able to turn or move or walk anymore, that person is going to be obviously more prone to pressure issues because they're not going to be able to turn and move themselves. When you sit in class and you're watching these videos, for instance, or you're sitting in a class at school, you're constantly moving. We can't help it. You can't just sit still for an extended length of time without moving and wiggling around because our bodies know that it needs more circulation. The other thing we see when a person gets old is that sensation. We said our skin's a source of sensation, and as you get older, the receptors for touch become a little bit diminished. So that can impact how healthy our skin is. Another problem that we see that can impact the skin is chronic oxygenation issues. Many of our residents we're going to take care of in the nursing home, they're going to have long-term respiratory issues like COPD, emphysema, or they might have heart conditions, coronary artery disease, or heart failure, where they're not oxygenating properly and they're not getting enough oxygen to all of the tissues. Circulatory issues. We looked at circulatory ulcers and when we talked about wound care, wound management, and again, circulatory problems, it can be an arterial issue, it can be a venous issue, it can be a heart issue. But all of that can keep the heart from pumping blood and oxygen throughout the body and throughout to all the tissues like it needs to. Elimination issues can also be factors that affect the skin. If you have someone who has incontinence, incontinent of urine, incontinent of bowel movement, critical that we're checking them frequently, that we're doing good perineal care, that we're keeping that skin as intact as we possibly can. Nutrition. Okay, and that we brought up with wound care as well. So with nutrition, we need to make sure that they have a good, well-balanced diet, that they have good protein sources, that they have enough carbohydrates for energy, that they've got all their vitamins and minerals, so all these chemical and enzyme reactions can happen throughout the body. And the other thing is hydration. We always need to make sure our patient stays hydrated. And sometimes you'll see with our elderly population, they don't want to drink as much. They don't want to go to the bathroom as much. They don't want to be incontinent as much. So they purposely don't drink as much, and that is not healthy for them. Unless that person has a condition that is putting them on restricted fluids, it is really important that we keep our residents as hydrated as we possibly can. So a pressure injury is also known as a pressure ulcer, also called a decubitus ulcer, a bed sore, or a pressure sore. And it's generally it's a localized injury to the skin and or the underlying tissue, and usually over a bony prominence, somewhere where you've got a bone that's so you've got a chair, you've got this person in the chair. So you've got them in the chair, and now their bone is sitting there and it's pushing that skin in between that chair and that bony prominence, and it's not letting blood and oxygen get through to it. So it is staged. We stage our wounds, we stage our pressure ulcers by the degree of the damage that there is. Now, what you're seeing here, a really, really common place to see wounds is right here. Let me see if I can get my little arrow right here. So right in this area, the sacral area. That's one of the most common places we tend to see wounds. But if you have someone who's chair bound a lot, they get them up in the chair to get them out of bed, but they sit in a chair all day long and they can't move and wiggle around themselves, these ischial tuberosities sometimes can break down. Now, we're going to look at staging of a wound, but this wound right here, we wouldn't even be able to stage this type of wound because it has all of this. It's called slough and purulent drainage. So slough is just dead tissue that's sloughing off, mixed with that purulent drainage. It's got this like jelly, goop basically in the wound. I can't tell how deep that wound goes until that's cleaned up. So sometimes wounds are considered unstageable until they can get cleaned down to good, clean tissue so we can actually see how deep a wound might be. So common pressure ulcer sites. So as I mentioned, the sacrum is probably the most common place you're going to see. The heels are also another area that's really common, especially if the person can't move their feet, they can't move their legs. We tend to see breakdown right here on the heels. You'll see it here, as I mentioned, on these ischial tuberosities. And then all these other places are places we might see it as well. The toes sometimes, especially if there's a bunch of heavy blankets and on them. You can see it on the hips potentially, the knees, especially if you're rolling them on their side, positioning them on their side, and you're not getting those, pillows in between the knee to the ankle to keep that them from rubbing. That's another area we tend to see breakdown happen. So what causes these things? Unrelieved pressure, not people not being moved. And so sometimes we see people come into the nursing home with these wounds because their families didn't know they needed to turn them every 2 hours. But when they happen at the nursing home, they're usually something that we do have to, once we get to a stage 3 and stage 4 wounds, we have to report those to the state because they should not be happening. Because if we're doing good care, really good care, we're moving our patients at least every 2 hours. There's no reason for this to happen to them. Now, I say that, and there are a few exceptions when people's conditions are so critical or they're dying that sometimes that these wounds can potentially happen. But the majority of the time, when you're seeing pressure ulcers happen at a facility, it's generally because we're not doing our job as good as we could have done. Okay, and our job is always to prevent harm. We always want to make sure we're taking care of these people properly. So unrelieved pressure, and then we talked about shearing and friction. So shearing is that sliding down where the skin just sticks to the bed and the person's sliding down in bed and their skin's stuck in another area, or we're dragging them up in bed but yet their skin is kind of stuck to it. That would be shearing. Friction is scraping of the skin. So where the body areas are rubbing together. Other things that are, so those are some causes, risk factors, breaks in the skin. If the person already has a break in the skin and then it starts rubbing or it starts, or you get any pressure areas to it, it's just going to continue to get worse. Poor circulation to an area, poor oxygenation to the tissues. Now I have moisture here and I have dry skin here. And I know that kind of sounds like an oxymoron. Dry skin can cause it, moisture can cause it. But overly dry skin can do this to a person. So overly dry skin, that skin tends to break down and can break open easier. So when you have a resident and you're bathing them and you notice they have really dry skin, we want to make sure that we're moisturizing, that we're putting lotion on it, that we're, keeping that skin lubricated. Now, on the other end of it, excessive moisture is not a good thing. So if they are incontinent of urine or bowel movement, really important that we get it changed right away to keep that skin dry. So you don't want moisture to just sit on the skin for an extended length of time, especially where it's going to be in warm, dark areas. So if you have someone who's really large, they're really obese and they have lots of skin folds, and those skin folds start getting kind of moist and they never fully dry out, the integrity of the skin starts breaking down. So yes, we don't want our elderly person to have their skin overly dry, but at the same time, we also need to make sure that people's whose skin is, super moist or wet, or they're sweating a lot, that we're drying that skin and making sure their skin stays dry in between folds. So so in this picture right here, you can tell she looks very, very underweight. Okay, and someone who's excessively thin, their bones are a little bit more prominent. Obviously, it's going to be easier to get the bones stuck between, the skin stuck between a bony prominence and the bed. It also looks here like maybe her circulation to her lower extremities aren't that good. It looks like she has some permanent discoloring of her feet. So that would make me think that maybe she doesn't have good good circulation to begin with. I've got friction happening here between the knees, which is a potential problem. And bed linens. We should always make sure bed linens are as wrinkle-free as we possibly can. Okay, it's not only going to help the person feel more comfortable and be able to rest better, it's going to help prevent anything from digging into the skin. So people that are bed rest or bed bound obviously are going to be at risk. We already mentioned that. If they're unable to move or have involuntary muscle movements, loss of bowel or bladder control, exposed to moisture, poor nutrition, poor fluid balance, problems sensing pain or pressure, circulatory problems, and as we mentioned, being overly thin or being overly heavy. Both of those can actually be a risk factor. And then just having a compromised immune system where your immune system isn't capable of fighting off disease, fighting off infections. So when we're staging pressure ulcers, and I really want you to be able to recognize a stage 1 pressure ulcer to truly understand it. Staging of wounds is something that if you go on for your nursing career, you go on to be an LVN or an RN, you'll really have to learn your stages, okay, of pressure ulcers. But it is something that, especially stage 1, you should always, any nurse should know that, regardless of, what level of nursing you're going into. And in a stage 1 pressure injury, the skin is still intact, but it has non-blanchable redness over intact skin. And what we mean by non-blanchable is if you just take your thumb or your finger and you just press it into your hand, so you just press it here into the skin of your hand, and you're going to see the skin turn kind of whitish, and then when you let it go, the color will seep right back into it. So when I press it down and it turns white, that is blanching. And so when you have a stage 1 pressure ulcer, you have redness over intact skin, but it doesn't blanch, okay? And it doesn't go away when you just roll the person off of it. A stage 2 is a partial thickness skin loss. So you have an opened area now. That skin has broken open, but it's just in those top layers of the skin. A stage 3 is a full thickness skin loss. So it's going all the way down to the fat layer. So it's gone through the upper layers of the skin, and now we're into the fat layer of the skin. And then a stage 4 is a full thickness tissue loss with muscle, tendon, and bone exposure happening. So you can literally see the bones or the tendons going across it. Now, some wounds are unstageable. I mentioned, let me go back to this picture right here. something like this, I could not even stage that correctly because I can't tell, is that going to the fat layer? Is it going all the way into the muscle layer? I can't tell until it gets cleaned up. So sometimes wounds are unstageable until they can get cleaned up properly. And then there's also what we call a suspected deep tissue injury. It's kind of a purple or maroon area. It's intact, but it almost has a clear look, like it's full of fluid on the, on the back side of it. So stage 1, I've got a reddened area on the outer part of the, like say the sacral area or the heel area or wherever this happens to be. It's still intact, but it's non-blanchable. Now, a lot of times CNAs will look at this and they'll say, okay, well, I don't have good circulation to that, so maybe I should massage it. Because we've talked about, back rubs and massages, and when you massage someone, you promote circulation, you relax them, you give them a sense of well-being, it's very restful for them. So you're saying, okay, I don't have good circulation to this area, so let's massage it and get some good blood flow to it. But when you massage an area of tissue that's damaged, you can actually cause breakdown of the underlying structures underneath it. So when you're already not having a good blood flow to an area, you don't want to be massaging it. So we don't massage reddened areas, okay, like that over bony prominences. Stage 2, the skin is actually broken open. Stage 3, you'll actually see some of the fat layer sticking through. And then stage 4, you will actually see muscle, or you might see tendons, or even little fragment or bone issues right there. So stage 3 and stage 4s are actually reportable to the state. The facilities are required by law to notify the state that this has happened at the facility. So if a person comes in with these from home, we need to make sure we document it, we take pictures of them, we document them really well so we can show that this wasn't something that happened at our facility. Because when it does, it's considered it's considered something that is healthcare acquired induced, and it's something that is usually considered to be a preventable injury. So something like this is, again, it has this purulent drainage. We would also call this a lot of times eschar because we've got dead tissue, some skin sloughing off, and then that purulent drainage right there. Again, can't fully tell how deep it goes until it's cleaned off. This right here would be that suspected deep tissue injury. It's kind of a purpley maroon color. You can see it almost looks like there might be fluid in there. Oh my gosh, try to be very, very careful with it because it's definitely, it can break open very, very easily. And it'll go from that to being like a stage 3 or stage 4 right away. Now, this is a kind of unique one. This is a Kennedy terminal ulcer, and it kind of looks like a deep tissue injury. And then, as I mentioned, they can break open really quickly and be a really deep, deep wound. This Kennedy terminal ulcer is considered an unavoidable pressure injury. It happens a lot of times 2 to 3 days before death. So when a person's in the dying process and their body's starting to shut down and they're not oxygenating well and their circulatory system is starting to shut down, they can go from having intact skin to having, a really, really nasty pressure ulcer within a very short amount of time. And those, because of the dying process, they do consider those an unavoidable pressure injury. So as far as prevention and treatment, a lot of times if the wounds are really deep, or if there's a lot of dead tissue and slough and purulent drainage on this, they're going to go to surgery to get this wound cleaned up. And they're going to need to make sure that they clean it all the way down till they have good viable tissue. So here they've got it all the way down to the muscle layer here that they've had to go to clean to get this all cleaned up. Now, as far as elimination goes, so if they have to do something like this, let's say this is on the bottom, okay? So this is on the bottom, and they've had to take them in for surgery, and they have to clean that wound all the way down to clean, good, viable tissue. And then they're going to put dressings on it to try to protect it. Now, we normally do not use urinary tubes. We talked recently about urinary tubes. We do not use those routinely for incontinence. But if you have someone who has a severe wound on their bottom and you're trying to keep that moisture and that urine from getting into that wound, they'll probably end up with a urinary tube till this heals. And when a person has a bowel movement, you're going to need to make sure you clean them up, and then you go, and if there's bowel movement that's gotten on the outside of that dressing, you're going to go let the wound nurse know, and they'll come in and they'll get that dressing cleaned right after the bowel movement. Fluid status and nutrition status, we've already talked about. Good nutrition, try to encourage them to eat as much as you can. Try to encourage them to eat their protein sources first. Try to make sure they're drinking plenty of fluids. And then we also want to think about protective devices to help keep pressure, even more pressure. Now, the other thing that I need to mention about tubes here is tubes are a cause of pressure ulcers. So I know when we talked about urinary tubes and oxygen tubing, if a person is laying on a urinary tube, that is going to cause a pressure. It can cause a pressure injury. We talked about oxygen tubing, how you need to check the cheeks and right here under the nose and right over the ears for pressure injuries. So tubes cause pressure as well. So anytime you have a patient with a tube, you've always got to make sure when you're turning them, when you're repositioning them, that you are, checking the tube. Where's it going to? How do I get it? How do I need to make sure I know where it is at all times and that the person's not laying on it at all times. So some of the things we do is we do specialty beds. Now in the nursing home, we tend to use a lot of air mattresses. In hospitals, they actually have beds that can inflate and deflate underneath the person. So if you have a person that doesn't turn much or that's really difficult for them to turn, they actually make beds that sections of the bed will inflate and deflate every so often just to relieve pressure underneath them, even if they can't turn. In the nursing homes, we use the air mattresses, but we also want to make sure we're turning our residents at least every 2 hours. They should be repositioned a minimum of every 2 hours. Use positioning support if needed. Range of motion exercises. Again, we really want to promote circulation for these people. Reposition residents in our wheelchair too. So yes, it's great to get your patient up out of bed, but if you get them up and you stick them in a wheelchair all day long, they've got to move too. So if they can't move around their own bottom, we can just take a towel and fold it in half and tuck it under one side of their bottom, and then an hour or two later tuck it in the other side of the bottom, and just constantly relieve some of that pressure. We use lift sheets. If you have a patient who can't move well on their own in bed, use lift sheets and lift them up in bed versus just dragging them up in bed. Always check skin under tubing. Know where your tubing is. Again, massages are great. They do help promote circulation, but not over those reddened areas. And we want to keep our linen as dry and wrinkle-free as we possibly can. And if we notice any reddened areas, if our patient's having any pain, any skin issues, we need to make sure we notify the nurse right away. Now, sometimes if they have a reddened area on their bottom, they may actually have you put like an over-the-counter ointment. We talked about how you're not allowed to do medications other than a topical over-the-counter ointment, like A&D ointment or Balmex. So if their skin is starting to get red and sore from being incontinent, that's a lot of times the nurse will tell you, go ahead and put Balmex on them when you clean them up and change them. Go ahead and put some A&D ointment on it. But we do always want to make sure that we're notifying the nurse right away when we notice anything wrong with our skin. As far as elimination goes, pericare. Okay, we need to do pericare every day and after incontinence. So normally think about this. You wash yourself once a day, and that usually takes care of things for you. Well, that's true for our resident too, unless they have issues of incontinence. So we do pericare once a day and after any episodes of incontinence. If they are incontinent, we want to make sure we're checking at least every 2 hours. We need to make sure that we're checking if they're incontinent, if they wear briefs. We want to make sure that we're checking, every couple hours to make sure that they're not wet. Wash the skin gently and pat dry. Remember, we don't want to cause extra friction. So, it's one thing when you're washing someone and there's water and there's soap, and you can rub that washcloth up and down because that soap is going to keep, friction from happening. But when you're drying a person, and now you're talking about you're drying the skin off, and there's nothing to lubricate that skin to keep the friction from happening, we would always pat dry. We should use pillows to keep the skin from rubbing together. And sometimes pillows are hard to find at the facilities. If you're having a hard time getting enough pillows, you can use a blanket. You can use like a bath blanket and put it in a pillowcase and use that to go between the knees and the ankles, so that skin isn't rubbing together. As far as fluid status goes, we always want to encourage fluid for our residents unless they're on fluid restrictions. So when we talked about our nutrition section, we said sometimes residents are on fluid restrictions and then we have to limit their intake, but most people can have fluids as they want them. So it's PRN, fluids PRN, as needed, as wanted, but we really want to try to encourage them for these people. Elevate the limbs that have edema. So remember, we talked about edema in a previous class. It means swelling of the tissues. So if we raise them up, sometimes it'll help that extra fluid get back into the main system, come out of the legs. And sometimes residents will wear these compression socks. So compression socks, you put them on, we turn them inside out to the ankle. And then when you put them on, they slide up the leg and they're a tighter pressure down here and it gets looser as it comes up the leg. The other thing you're going to notice is a lot of pressure ulcers are they're called pressure socks pressure socks or compression socks, or they're also known as anti-embolic devices. So they have holes right here over the toes, and the reason that is because they are tight. They do put compression, and we want to make sure it's not too much compression for the person. If the socks are too tight, their feet might go numb or tingly, or the color might not be as good. So those holes on the toe above the toes are so you can pull it over the toes periodically and check the circulation. Make sure they can feel their feet, that it's not numb and tingly, that the color still looks good to them. Now, these can be a little hard to get on sometimes. One thing you don't want to do, sometimes I see CNAs or my students will say, well, let's put some lotion, it'll slide up easier. The lotion actually makes it stick worse, and it can kind of start breaking down the fabric of the socks quicker. So if anything, you can put a little bit of powder on it if they don't have any respiratory issues, and that might help it slide up a little bit easier. Some residents don't care for the socks, but they'll let you use, they'll let the nurse put ACE wraps around the feet. Again, just to kind of put that pressure on those lower legs if their legs are swelling up. And if you've never worn them, we also recommend them for nurses because compression socks are fabulous for nursing because you're on your feet all day long, and it really helps with leg fatigue. Nutrition, encourage and assist with the proper diet. If they are overly large, if they're obese, always check in between skin folds. Make sure the skin isn't breaking down. Make sure it's staying dry. And if they're really thin, check our bony prominences at least every 8 hours to make sure, at least every shift, just take a look at all that. You got to reassess the skin every shift. Every shift you need to look at your resident's skin and just to make sure it's not breaking down. Now, some protective devices we can use. This right here is called a bed cradle. It's called a bed cradle. So this fits underneath the mattress, and this part links onto the top part, and then it's just got this bar that goes over their feet, and then the blankets, the sheets, blankets, bedspreads can come over the feet, so it's not putting extra pressure on the toes, extra weight that's pushing their feet down into their heels better. So if the person has heel or toe issues, this is a nice thing to do for them. If you do home care, you can make your own foot cradle. I mean, it's just a box with a pillow in it. I mean, it works fine. So something in a home care setting, this would be a great thing to do. If they've got problems with their heels are starting to get red and the heels are starting to break down, they have these foam devices that obviously the heel, it's supporting the leg and it supports the weight of the foot, but the heel is staying loose. And then they also make foam boots that actually just fit over the entire foot and lower leg. Egg crate mattresses, I can't say this is probably the most, it does provide minimal support. The egg crate mattresses are generally only an inch and a half tops in places. It's better than nothing, okay? But an air mattress it will provide a much better protection for them if they're having wounds. So an air mattress, it has a compression device on it with a hose that goes into the mattress, and that mattress stays inflated, and they have these rolls are like about 3 to 4 inches of air going through it. So that person's bony prominence has 3 or 4 inches of air in between that and the hard mattress. Now, the one thing is we don't want a lot of extra linens on this. So usually you just put as minimal linens as you can between the air mattress and the person, because you're really wanting to let that air be in between it. Okay, so you're not having any extra pressure. So we try not to put a lot of extra linens on the bed if we can help it over this air mattress and in between the patient. And as far as putting a person on their side, so when we reposition a person on their side, you are going to want a pillow underneath their back, but then you have them roll back on it. So you don't want to position them on their side where this bony prominence here. So I've got my bony hip prominence here, my bony hip prominence here. If I roll them all the way over on their side, then this is going to start becoming a pressure issue. So if I put that pillow behind their back and then I have them lean back against it, it keeps the hips tilted here at this 30-degree angle, and that way you don't have pressure on either bone. The other thing is we always want a pillow here from knee to ankle, so it will keep friction happening from the knees and the ankles rubbing together. And then a lot of people like an extra pillow sometimes just to kind of hold on to, just kind of grab onto for their arm. So if we have an extra pillow, we can definitely do that as well. If you do happen to get a sideline position for state competency, we do put a pillow behind their back. We do a pillow under their head, a pillow from knee to ankle. We give them one to hold on to on this top arm, and always make sure this left arm isn't pinned underneath them, okay, when you're doing a sideline position. Now, if you have a patient that has prosthetic devices or a type of splinting device or a prosthetic leg, you do need to monitor that skin every shift under a prosthetic device. So once during your shift, it needs to come off so you can take a look. Is it causing any pressure ulcerations? Is it causing a rash? Is there, you want to check and make sure it looks like it's fitting properly. When people have these prosthetic devices, if they gain weight, they don't fit properly anymore, and it can cause pressure issues for them. Splints, the same thing. We want to take them off at least once during our shift. Make sure that skin is clean and dry before we put it back on, and just check that skin and make sure everything looks okay and that they aren't having any pain. If they are having any problems, any skin issues, any complaints of pain to their skin, we've got to make sure we're notifying that nurse right away. Now, some legal things to keep in mind. It is our duty to keep residents from harm and to prevent sores. It's our duty. It's our responsibility. You guys, when you go into nursing, it is do no harm. So there are increased legal risks if no preventative measures are taken. So if that person gets a stage 3 or a stage 4 pressure ulcer, it is reportable to the state. The facility has to report it to the state. They come in and they investigate and they look to see if were we turning our patients every 2 hours? Were we doing good skin care? Were we taking measures to promote circulation? And if we weren't, then that facility is going to get fined, and fined heavily. So I know sometimes, my students will say, well, I bet you they probably don't even report it, because why would they want to report it if they're going to get in trouble? Well, I'll tell you, if they don't report it, if it happened at the facility and they don't report it, and let's say the family calls the state and says, my loved one has this horrible sore and I don't think they're taking good care of him. Now the state's going to be there like the very next day. The state's going to be there checking everything out. And because the facility didn't report it, they get a massively huge fine. And if it happens on a repeated basis, their facility can get shut down. So they do report it, okay? But again, we don't want any pressure ulcers to happen. None, not even a stage 1. When we have a patient who can't move, we need to be moving our patients. We need to do range of motion. We need to keep our patients active. And that is our responsibility. We need to do good skin care. And if we do notice a stage 1, we've got to jump on it right then. We need to think about specialty beds, getting them moved, getting them repositioned to prevent this from happening. Because it's not just the legal issue here. You guys, if you get a pressure ulcer and it doesn't heal properly and it gets infected, let's say it gets into the bloodstream and it causes a sepsis throughout the body, the patient can die from it. They can die from a wound on their bottom because we didn't take the time to turn them enough. And there's no excuse for that. So we always have to make sure good skin care, bathing them regularly, making sure that skin is clean and dry, making sure that we're moving our residents as much as we can. Now, there will be times you'll have a resident refuse to be turned. You better make sure we document that. Okay, so if they do end up getting sores, it's been documented that we were trying to get them repositioned, but they were refusing. And when a patient does tend to refuse to get turned regularly, we really do need to think about those specialty beds for them, okay, to keep them safe. Now, we have been talking about documentation in this class, so I wanted to show you a long style charting and a short style chart, or an electronic charting. So I've got the date and the time. It says, while assisting resident with a tub bath, a blister the size of a quarter was noted on the outer aspect of the left heel. A 1/4 inch red area around the blister, no drainage noted. Resident states it hurts a little, so they put that in quotation marks. She said she thinks her shoes are rubbing. Ask Barbara Lane, RN, to observe the area. You really only have to sign first initial, last name, and your title. But again, if you document a problem, I would not document that I found that blister and not document what I did about it. So anytime there's a problem, anytime that you see something wrong, if you're turning it over to another person, you want to make sure you're documenting who you're turning it over to. You don't want to just say the nurse was notified, because which nurse? And then if it doesn't get taken care of and it ends up going to court, they're going to say, well, who did you report it to? And you're going to say, well, I don't know. I mean, it might be 2 or 3 years later before something goes to court. So you need to make sure you're always documenting who you turned the problem over to if it's not something we can take care of ourselves. And this is definitely something we would have to report to the nurse. Now, electronic charting is a little bit different. So here I have a male. He also happens to have a wound on the ankle. So they've marked redness. They've marked a blister. And then they put, while assisting with a shower, blister the size of a quarter was noted. Inner aspect of left heel. So this actually, inner aspect. Okay, so right there. There's a 1/4 inch red area around the blister. No drainage noted. States it hurts a little. He thinks his shoes are rubbing. Nurse notified, Mark Rhodes RN. So whether we do it electronic charting or we do old school charting of paper charting, we've got to make sure it's documented, and we've got to make sure we report who we've turned it over to. Okay, so I think that's going to conclude our talk on pressure ulcers.